Hello, my name is Daniel Destiche. I am a third-year radiology resident here at the University of Arizona. Under the guidance of two of my mentors, Dr. Samuel Rogers and Dr. Jennifer Becker, I am going to be presenting a case of polymethyl methacrylate embolic cerebral infarction. Our case begins with a young female presenting to the ED with acute dyspnea immediately after cosmetic gluteal injection with polymethyl methacrylate in Mexico. Her workup revealed a leukocytosis, lactic acidosis, mildly elevated troponin, and a right heart strain. The patient was admitted to the ICU in shock and was intubated. Here is some cross-sectional imaging of the chest, first performed in the ED and subsequently 5 days later in the ICU. As you can see, CTA of the chest in the ED revealed multifocal, patchy, ground glass opacities primarily in the bilateral upper lung fields, without pulmonary embolus. 5 days later in the ICU, repeat CTA demonstrated significant interval progression of nonspecific multifocal airspace disease. The patient underwent a CT of the head without contrast, which revealed nonspecific scattered bilateral supratentorial white and gray matter hypoattenuation with loss of gray-white matter differentiation. The patient then underwent MRI imaging of the brain, and as you can see, the axial susceptibility weighted imaging demonstrates diffuse microhemorrhage supratentorially and infratentorially, most prominent in the corpus callosum and bilateral periorlandic regions. DWI and FLAIR imaging revealed infarcts in the external watersheds, the internal watersheds, as well as the deep gray and cortical gray matter. This case is an example of a phenomenon termed the star field pattern, which is described as scattered restricted diffusion within regions of confluent T2 hyperintensity. It's been described in the setting of cerebral microembolism, particularly fat microemboli as well as cholesterol microemboli, in the setting of disrupted atherosclerotic plaques that shower to the brain. However, this case is something completely different. It is polymethyl methacrylate cerebral microembolic infarction. And I'm going to finish my talk on a brief discussion of PMMA, also known as plexiglass. PMMA has medical uses. In the orthopedic world, it's been used for hardware fixation and in ophthalmology for intraocular lenses. Cosmetically, PMMA has been FDA approved as an alternative for gluteal augmentation versus skin flap, liposculpture, and implant placement techniques. Local complications are the most common, including hematoma, seroma, granuloma, scarring, and infection. A blunt-tipped atraumatic microcannula is used so that you do not injure vessels, because in the chance that you do injure a vessel, you can induce intravascular and systemic complications. For the microsphere preparation, which is used cosmetically, arterial occlusion is considered the most dangerous complication of fillers. Systemic embolization is not well described in the medical literature. However, as you can see in these grabbing article titles in popular magazines, there is a high rate of clandestine systemic complications. Here are my references.